Hello everybody, thank you so much for tuning into my presentation. Today I will present a global health advocacy campaign focused on an issue that I feel passionate and connected to. As a DONA certified and former community doula, I am advocating for the prevention of obstetric fistula in rural Nigeria through the integration of trained community-based doulas into the maternal health system. Rather than concentrating solely on the surgical repair after the injury occurs, this campaign emphasizes prevention by addressing delays in accessing emergency obstetric care. Obstetric fistula is a preventable childbirth injury caused primarily by prolonged obstructed labor without timely surgical intervention. It results in a hole between the birth canal and the bladder or rectum, leading to chronic incontinence, infection, and profound social stigma. The World Health Organization estimates that between 50,000 and 100,000 new obstetric fistula cases occur globally each year. Nigeria is considered the country with the largest share of global cases, accounting for approximately 40%, according to the United Nations Population Fund. Fistula disproportionately affects rural low-income women who lack access to timely emergency obstetric care. The disproportionate rates of fistula demonstrates a failure of obstetric systems to appropriately care for laboring people. I wanted to include a map of Nigeria so you get an idea of the geography of the area that we're talking about. So this is kind of the line that separates the northern from the southern states. Districts including Sokoto, Kano, Kaduna, right here, Katsina, Kebbi, Zamfara, kind of this upper, western region. These are the states with the highest fistula cases, early marriage, which unfortunately also includes child marriage, and lack of emergency access to obstetric care. These are all factors that contribute into the disproportionate rates of fistula. Research consistently demonstrates that delayed access to emergency obstetric care is the primary driver of obstetric fistula. In rural northern Nigeria, skilled birth attendance rates remain significantly lower than the urban regions, which increases the risk of prolonged obstetric labor. This campaign is grounded in the 3 delays model developed by Thaddeus in Maine. The model identifies the 3 major contributors to maternal mortality and injury: delay in deciding to seek care, delay in reaching care, and the delay in receiving adequate care at a facility. Community-based doulas can directly intervene in the first delay by promoting birth preparedness through childbirth education, recognizing prolonged labor early, and providing continuous support pre-labor and during labor, and finally facilitating timely referral to skilled providers before the injury occurs. Globally, the UNFPA campaign to end fistula has historically prioritized surgical repair, rehabilitation, and reintegration services. WHO provides maternal health guidelines that emphasize skilled birth attendance. In Nigeria, the Federal Ministry of Health has developed a national strategic framework for the elimination of obstetric fistula. The United States contributes through USAID, which stands for the United States Agency for International Development, maternal and newborn health programming, and additional support comes from different foundations and different partners. However, despite these commitments, prevention remains comparatively underemphasized compared to treatment of the injury. Much of the funding focuses on treating existing cases rather than preventing it and strengthening community-level systems that prevent the injury from forming in the first place. That is where the gap lies. Pretty much there is a gap in insufficient investment in community-based delay reduction. In many high-burden rural districts in northern Nigeria, community birth supporters are not formally integrated into referral systems. While surgical campaigns address existing cases, limited funding support structures birth preparedness education and early danger sign recognition at the community level. Without strengthening the link between patients and facilities, prolonged labor continues to result in a very preventable injury. The primary ask of this advocacy campaign is that USAID Nigerian Mission and the UNFPA, United Nations Population Fund, Nigeria County Office, allocate targeted funding to integrate trained community-based doulas into maternal health strategies in 5 to 10 northern regions with disproportionate cases of obstetric fistula. Specifically, this includes funding for doula training and recognizing prolonged labor and obstetric danger signs, formalizing referral pathways with midwives and facilities, and launching a 12-month prevention pilot program. This program model is not meant to serve as a replacement for a skilled obstetric care, but rather is a structured preventative bridge that reduces delays before pregnant people reach facilities. Excuse my coughing, you guys. I have been very sick. This intervention directly addresses the first delay in the 3 delay models. By improving early recognition and birth preparedness, it reduces the likelihood that labor will progress to obstructed, prolonged states without medical support. Prevention is also cost-effective. Surgical repair, rehabilitation, and social integration are all resource-intensive and often lifelong processes, with some fistulas requiring multiple surgeries and repairs. Investing in community-based prevention reduces long-term health expenditures while protecting women's dignity and autonomy. This proposal aligns with the Sustainable Development Goal 3, which seeks to reduce maternal mortality rates, and Sustainable Development Goal number 5, which promotes gender equality and women's health rights. The primary targets for this campaign are decision makers with the funding and political authority in Nigeria. So the primary targets include USAID's Nigerian Mission's Maternal and Child Health Office, the UNFPA Nigerian County Office of Reproductive Health, and Nigeria's Federal Ministry of Health Department of Family Health. The secondary target audiences include the World Bank, the Parliamentary Health Committee, and different non-governmental organizations / nonprofits. These institutions were selected because they're the ones that control the budget, maternal health workforce frameworks, as well as program implementation and authority. So there's a 4-part advocacy strategy for this advocacy ask. So first, an evidence-based policy brief would be developed, presenting Nigeria-specific burden data, defining the prevention gap, and outlining a 12-month pilot proposal. Secondly is when formal meetings and requests would be submitted to take place to present the proposal in alignment with national maternal health strategies and the Sustainable Development Goal commitments. Third, coalition building efforts will engage Nigerian maternal health non-governmental organizations to demonstrate a broad community support and increase policy legitimacy. Fourth, the proposal will be elevated within the maternal health technical working groups and relevant maternal health awareness campaigns to maintain visibility and momentum. Ultimately, the objective is to secure a funding commitment for the pilot implementation in the northern districts. So the leave behind would look like a concise 1-page executive policy brief tailored specifically to the USAID Nigerian and UNFPA's Nigerian leadership. It will include 3 key strategies illustrating Nigeria's disproportionate global cases of obstetric fistula, a clear explanation of the prevention gap, a detailed pilot proposal with a projected budget and measurable outcome indicators such as increased timely referrals and reduced prolonged labor cases. The rationale for this format is practical. Policy officers operate under time constraints. A concise, budget-oriented document Ideally increases the likelihood of a follow-up discussion and funding consideration. The leave behind directly would link the identified problem to a specific policy change being requested. Specificity is key here. Obstetric fistula is not an inevitable part of birth. It is the result of preventable delays in accessing emergency obstetric care. This program, by integrating trained community-based doulas into maternal health systems in rural Nigeria, we can reduce the delays, strengthen referral networks, and shift from this idea of reactive repair mode to proactive prevention. When systems are strengthened at the community level, we see a decline in injuries. Prevention is both possible and necessary. Investment in education and care of women is in the best interest of humanity. Thank you so much for tuning in, and I'm happy to answer any questions.